grandparents in bed most of the time, not eating, and basically they do not have a very high temperature and do not use the temperature as a parameter for gauging signs and symptoms of infection. And those same infections, whether or not they produce in sputum, like the young adult, they do not produce as much because they're not able to bring up the sputum. You actually look at the chest wall and you'll see evidence of them having difficulty breathing with evidence of intercostal retraction. And this is when we know when the lungs itself starts to get involved. It's not only the fact that they're coughing or they're getting hoarse, but the fluid and everything is retained in the lungs. They do not have the respiratory excursion of the diaphragm to be able to bring up as much sputum as possible. They do not have the intercostal muscles to contract like the young adults and bring up that sputum. So what happens in the elderly, they get this fever and chill going on. We give them the Tylenol, we give them the Motrin, the fever comes down a little bit, but at the same time we're not treating the focus of infection. The most serious complication in an elderly person at that stage is maybe we allowed an upper respiratory tract, the sinus infection, the ear infection, which probably might not be a fulminant infection. But then it becomes a low respiratory tract infection, which initially was a tracheitis. They have a little bit of hoarseness when we try to talk to them. They have difficulty swallowing. But in that elderly person, that basically that infection, which now becomes an acute bronchitis, now becomes a bronchitis, and now becomes a pneumonia, a bronchopneumonia, which involves in the lungs, that in itself is still treatable as an outpatient. But when that elderly person now presents with a lobar pneumonia, in which you actually going to expect it to get consolidation of the lungs, meaning that lungs is no longer viable in terms of air gas and air exchange. That lung now is consolidated, it's now solid. So instead of being nice and spongy, that is now a very solid lung. And at that point in time, the elderly person should be, without a doubt, be admitted. But we should not be waiting for that stage, because that is a stage in which infection starts to spread from the lungs into the systemic circulation. You start to get fever, chills, and rigors. Now you have a longer hospitalization, and also in addition to that, the increased morbidity and mortality in the elderly patient. The same applies to our immunocompromised brothers and sisters, basically the ones with HIV, the ones with leukemia, the ones who are being treated for cancer. Cancer of the prostate is an immunocompromised disease as well as any other cancer is. So at all times we should be cognizant of the fact that the elderly, the neonate, the immunocompromised do not tolerate infections as much as the young adults. Those who are the young adults and the ones in their 30s and their 40s obviously can tolerate an infective process much longer, and probably with symptoms persisting for a while. But here again is that yes, we can tolerate it with the fever and the chills, with Tylenol, etc., and something for the coughing and something for the over-the-counter for the sinusitis. But when you start as an adult, a young adult, to start to have blood-tinged sputum and start to have hemoptysis or blood within the sputum, that's the time you need to start to worry. When you start to get fever and chills persisting for over 2 to 3 days, when you start to produce yellow-green sputum, when you start to have difficulty breathing and evidence of bronchospasms, you get this wheezing sensation coming out of the lungs. It's not only that the areas are becoming narrow, it means that the mucus and the secretions are much higher than can be tolerated. And you can also suffer with a bronchitis, can also develop a pneumonia, whether it be a walking pneumonia or bronchopneumonia. It's still the same, we need to be treated. So in the younger adults, they take a longer time before they get to the physician. But in addition to that, they probably wait for the infection to spread to the systemic circulation with the fever chills before being seen by the physician. A few days ago, I was passing through the emergency room, and I happened to notice a patient of mine crying or sobbing by the bedside of an elderly patient. I recognized the face of the patient, being a regular person who comes to my practice, and I asked her what is going on, why is she crying? And then she introduced me to her elderly mother, who was lying on the stretcher and with drips going, and basically she obviously, the patient looks very, very worried, and so does our daughter. So I asked her exactly what is happening, and within sobbing and tearing, she explained to me that her mother has been diagnosed with an aneurysm of the abdominal aorta, a suprarenal aneurysm of the abdominal aorta, and she was just, in her own words, she was just told by the doctor that it will rupture and her mom will die. And she thinks, in her opinion, that as her mom is too sick to undergo any surgery. So then I was waiting for an answer as to what is going to be the next step. Because in decisions like these, obviously, we need to be educated as to what is going on. And sometimes as relatives, as parents, and as children, we are not properly informed as to what is exactly going to be taking place and what are the risks involved. My immediate reaction was to ask her, who is the doctor, so I can talk to him as to exactly what is going on. Since it was not my patient, but I knew her, is to see what is the size of the aneurysm. And obviously, all of us are aware that what the blood vessel, an infrarenal abdominal aortic aneurysm looks like. This is the aorta, and this is the descending aorta as it goes through the abdomen, as it supplies the major blood vessel in the body, as it supplies blood to the kidneys itself. What happened in this elderly patient, she had a dilatation involving the abdominal aorta in this area. But she was an 80-year-old woman in which it had swollen to such a degree, over 5 centimeters, which basically meant that the chances of a rupture, it was actually, when I examined it, it was pulsatile, it was enlarged, it was a midline, and obviously I could not make the diagnosis if it's going to rupture or not. But there are guidelines to follow that says to you, if an abdominal aortic aneurysm, or the dilatation of any major blood vessel, reaches a particular size, the chances of rupture is high. And these studies were done based on post-mortem specimens over the years, that what are the chances of an aneurysm rupturing in any person. But the couple of things that concerned me here was the simple fact that the surgeon did not spend enough time explaining to the woman that basically her mother, even at risk for the surgical procedure of clipping the aortic aneurysm, actually clipping it means opening it up and creating a prosthetic conduit that carries the blood, carries a risk. The surgery itself carries a risk. What he did not explain to her as well is that having aneurysm when it ruptures guarantees that you're going to die instantly. So what should have been explained at that time, both to the daughter and to the mother, and the decision should not even be made by the daughter, because the mother was a very cognizant and a well put together 80-year-old. So the decisions were all screwed up at that point in time. And I'm alluding to this not because I think of the case itself, but I think the decision making that we do when we face with difficult decisions to make with parents and death and dying are sometimes not the right ones. What should have been done in a case like this is, if the daughter did not understand everything the doctor says, doctor, why is it that my mother is going to die during the surgery? What are the risks she faced with? And if those risks outweigh the benefit, you know she's going to die from the rupture of the aneurysm regardless, whether it be today, maybe a couple of weeks or months. The surgical procedure is a much safer investment in your mother's life. And what the surgeon should actually have explained to her, obviously sat down and explained to her, if we don't do anything, it ruptures, your mom will die. If we now go into surgery, yes, there's a risk, but your mom is a healthy 80-year-old. She will be able to tolerate surgery. None of us can predict what the eventual outcome is going to be, but we can say that the best of our medical knowledge, she will survive that surgery. And in fact, she did survive the surgery. In fact, what the discussion afterwards was, I explained to her that it was going to rupture if you don't do anything, but let's at least look at the risk factors and ask the anesthetists and the surgeons, what is it in their opinion? And we went through with them, asking very, very clear questions as to how long the procedure is going to take. If the outcome is not a good outcome, what are the chances of it being a good outcome? Is it a 60-40? Is it a 70-30? And the outcome became extremely good, knowing fully well all this elderly woman had was mild elevation of hypertension. The rest of our EKG, the rest of our blood findings, everything except for mild elevation of cholesterol as well. Everything else was perfect. But my message here is not about this particular patient. But when you're making decisions, the daughter was making a decision for her mother, even though she was well aware of what was going on. Obviously aware that her daughter is the one who takes care of her, and probably she thinks that the daughter will do it in her best interest, and the daughter thought she was doing it in the best interest. But there are three things that went wrong in this particular scenario. One, the daughter made a decision for the mother, even though the mother was aware that she was not going to have the operation and can die spontaneously. The mother should have been told and asked to make that decision and not depend on the daughter. The daughter, for all the emotions she's going through, should have been told explicitly by the surgeons and by everyone else involved exactly what the nature of the operations and what would be the outcome if that operation was not done. And the physician, obviously knowing that this woman is at a very good chance of surviving surgery despite her age, despite statistics, should have been much more firm with the patient and with the relative, informing them that, look, this is what I'm faced with. Your mother will survive and probably live for maybe many more years if you make the right decision. So at times, take a step back, ask for more information before rushing to conclusion, especially in a hospitalized patient. One of the more common diseases that affect the legs is varicose veins. Varicose veins is present in about 20% of the population, but to a varying degree. Initial symptoms of varicose veins could be something as vague aches and pains on walking for long distances, to frank signs of seeing these large tortuous veins that seem to be popping at any point in time. But a lot of the patients have between that very vague symptom of having the aches and the pains and the tiredness of the calf muscles on long periods of walking to the ones of the tortuous veins. When we look at the anatomy of the venous system and try and understand why is it we develop varicose veins, or how is it we develop varicose veins, then we can probably try and prevent them from becoming these large tortuous things that look as if they're like snake-like things ready to pop with the extreme blue discoloration. If we look at the human foot itself, obviously the arterial blood drains into the arterial blood coming from the heart itself is obviously that supplies the blood from the heart down to the inferior to the descending aorta. The ascending aorta goes to the top, the descending aorta, then to the femoral artery, and then to the leg itself. So that blood now pumped by the heart through the abdominal aorta to the legs now sends the blood and feeds the oxygen to the leg. Now what happens then when the oxygen goes to the cells itself through the lymphatic system? Now it needs to have a mechanism to get back to the heart itself, so it can be pumped to the lungs and get oxygenated again. So it's a perpetual flow of blood from the heart, the arterial blood, through the heart itself, through the big blood vessels, the one that goes to the head through the ascending aorta, and then the descending aorta that supplies it to the legs and the rest of the abdomen and the rest of the body. Now when that blood goes through the arterial system, then it enters into the capillaries, feed the cells themselves, and then is drained back through the lymphatic system and then to the venous blood supply. So when we look at the venous blood supply, and you don't want to know the names of the peroneal, the femoral artery itself, well, these small tributaries of blood actually enter into the venous circulation and then carry this blood right back to the femoral vein and then into the iliac veins and then into the inferior vena cava, before being pumped back into the heart, and then is pumped from the heart into the right side of the heart, into the lungs itself, and become oxygenated again, and then starts the whole process again. Well, now what happens when there is evidence of pooling or stasis of blood? That must either the muscle pump is not working, or the perforators that sends the blood from the venous circulation to the larger venous blood vessels are incompetent. That blood now remains behind, and those veins become tortuous. And it can occur at the very local levels that you have the perforators, or it can occur at a very high level, the saphenous femoral area here, which can actually cause the pooling of blood in the legs itself. We also know quite commonly when we become pregnant that the pressure of the uterus itself on the inferior vena cava basically can cause stasis because of a mechanical obstruction and cause pooling of the blood in the leg. Distribution of that fat is within the cytoplasm of the cells. If it's on the abdominal wall, we know the risk factors for insulin resistance and increased risk for diabetes. But when it happens in the coronary blood vessels, that we're at least increased risk for, then we notice there's also a narrowing of those blood vessels. And there's also infiltration of the fat cells around the endothelial lining, thus decreasing the caliber of the coronary arteries. And then it increases our risk factors for having coronary artery disease. But what it also tends to do on the pericardium of the heart is increase the fat infiltration in the muscle, the myocardial muscles themselves. And that in itself, when it actually does this, also tend to weaken the muscles themselves. In the fact of actually the motivating factor for us, whether or not it be to increase our life expectancy, the fact that among the disease processes that are associated with obesity, if it is not linked to a disease condition through which we have no control and is due to a relative increase of the amount of calories that we take, then it's very, very important we realize that obesity is a condition that is associated with increased morbidity and mortality. And at all times, we should try and work towards decreasing our food intake, decreasing those foods that actually have a high caloric intake, including alcohol, and obviously sweets and things like pera, etc., things that we commonly snack on that have a high caloric intake that results in fats. When it's absorbed, it tends to result in fats being deposited in the areas of the body that's associated with increased diseases that we commonly see. In my years of private practice in Richmond Hill, Queens, I have started to see obesity in a different light. Obesity, as described in our textbooks, basically defines this as a clinical condition of increased weight gain associated with increased incidences of common disease conditions of diabetes, hypertension, hyperlipidemia, coronary artery disease, joint aches and pains, dysfunctional uterine bleeding, etc. But I've started to see it in a light more of a psychosocial problem that we have within our community. And lots of times it needs to be addressed much more at a level in the home environment, and also in the classrooms as well. We tend to look at the obese child as being someone who looks at themselves as essentially normal. But in a public school system that is extremely cruel at times with peer pressure, the obese child is lots of times actually being subject to lots of remarks that sometimes that basically could result in a very low self-esteem. In my private practice, I've noticed that a lot of the kids I see tend to have a lower self-esteem than they ordinarily would have had as a sibling who is probably a lot less heavy, basically a lot more self-esteem. It's not as simple as that, but across the board, I tend to see it as a psychological factor that is being played out at this point in time. The younger child who is obese, and actually a lot of this can actually be in the home environment as well, because the mother or father who is obese cannot use themselves as role models and examples to the kids and basically say to them, well, I need you to start losing some weight because I'm starting to eat less of carbohydrates. I do not eat late at nights. I do not eat any sweets now since I've been told that I'm at increased risk for becoming diabetic. I also try and exercise 3 to 4 times a week. And I also do not look upon my obese self or my increasing body weight as being an attractive condition. Now, I would also like you to do the same. So it's the matter of setting an example for your child is also extremely important. But what I think is what happens in the school environment as well, with the increased amount of juices and simple carbohydrates and relatively inexpensive food, it actually results in a status in which the child eats the junk, which is increased amount of carbohydrates, whether in the form of pizza or simple sugars, in terms of the sweetened drinks, and then tend to eat less of the better food that is probably prepared at home. And a lot of times the parents complain that, I cook proper food at home, but I don't know what the child eats in the school. And at the same time, when you eat in the school, you don't have an appetite for what is cooked at home. Also, in addition to that, is that when that obese child is actually denigrated by their peers, then they tend to try and use all sorts of means to cover up for that. Their self-esteem is low, they dress improperly, and then in addition to that, they may find friendship in friends who are of a similar kind, and finding that they find solace in doing things to make themselves more attractive, and things like dressing inappropriately. Also, in addition to that, engaging in habits that make them more acceptable. For instance, starting smoking at an earlier age, starting alcoholism at an early age. And I'm not saying this is across the board, but from my observation after 20 years of private practice in Richmond Hill, I'm starting to see as a trend that you should try and look into the condition of a child. And basically, if they tend to be eating, despite the fact you explain to them what the disease conditions, etc., despite the fact you are seeing them with an increased amount of acne on their face, increased amount of fungal infection, increased risk of dysfunctional uterine bleed, I also find that basically the kids themselves, when they're actually being ridiculed on an average day of being fat and being called all sorts of names, tend to at least use that as a solace and basically seek friendship with those of which are obese. And they continue the habit of eating simple carbohydrates, which in fact just perpetrates the problem of the obesity. In addition to that, the medical factors, especially in the young girls, is basically the fact with dysfunctional uterine bleed and an increased risk of pregnancy because they're not aware when their last period was. Because of the fact of obesity causes an increase among the fat cells to secrete more estrogen, they tend to suffer from dysfunctional uterine bleed, and the periods are not regular. In fact, the periods come every 2 to 3 months, sometimes never. And the mothers are become very difficult for the parents to monitor the menstrual cycles of these young women as well. For the young men who happen to be obese, they tend to take a less active part in sports. So they tend to be more inclined to be inactive, which perpetrates the obesity. They tend to want to involve themselves more in computer games, etc., and a lot of video games, rather than trying to pay attention to the fact of ways and means to losing the body weight, i.e. eating less, exercising more, and trying to maintain the ideal weight for your height. So in addition to our community being faced with obesity as an increasing health problem, especially with our underlying risk factors for hypertension, diabetes especially, and high cholesterol, we also face with the simple fact of the psychosocial problems that it is creating in our kids. And it is my plea to you is that basically in our home environment, let's at least address the issue with obesity very early in a child's life, so at least to make sure they are not encumbered by the additional psychosocial problems, rather than, and in addition to the medical problems that are created based on the fact of obesity that we cannot control at times.